So the usual history that I get in my clinic is that the child had a throat infection or an ear infection and was given a course of amoxicillin. This is the most common antibiotic that's prescribed in children. And they then developed a rash. So the rash could either be immediate with hives and swelling, or it could be a delayed rash, like a pinprick rash or a mottled rash. And these types of rashes are characteristic of a delayed reaction to an antibiotic. But the confusing thing here is that often the infection itself can cause these types of rashes as well. So certain types of bacteria and viruses can stimulate the child's immune system to produce rashes like hives and swelling, or also these little pinprick or mottled rashes. So it's sometimes difficult to know if that child has had an allergic reaction to the antibiotic or whether it was just the infection that caused the rash. And so what's really important is to delabel the child from a penicillin allergy or amoxicillin allergy. And to do this, it's a very standard way of doing it. They usually can have some tests beforehand and then would actually come in, take a dose of the amoxicillin in hospital when they're well, and then continue for 3 days to see if they develop any immediate or delayed symptoms to that antibiotic. And it's really important to do that because if you're not able to take penicillin types of antibiotics, you are then restricted in the types of antibiotics you can take, and some of those other antibiotics can have more side effects. So most children that I see have had a history of exposure to amoxicillin. And so I would say that amoxicillin is the most common type of antibiotic history of exposure. Now, whether that child's actually allergic to amoxicillin or not remains to be seen. And in the majority of cases that I see in clinic, the child is not actually allergic to the amoxicillin once we do the supervised introduction and prove that they are not allergic. And so we then know that the rash that they had was due to the infection itself rather than the antibiotic. This is very important to discuss with your doctor, and it's important that you know and also that your GP is aware of this. So an individual who has a penicillin type of allergy, or they think that they may have this type of allergy, they need to avoid all types of penicillin antibiotics. So that would include things like amoxicillin or another antibiotic like co-amoxiclav. And in terms of the alternative antibiotics that are usually recommended, they would be in the form of macrolides. So that would be the types of antibiotics like erythromycin or clarithromycin or azithromycin. And they could be used for oral medication. But then for intravenous medication, it can become more complicated. And it's important to see a specialist for this. Yes, children can outgrow their antibiotic allergy, but actually what we find is that in the majority of cases, the child was never actually allergic to the antibiotic, and that when you go through the process of testing and introducing the antibiotic under supervision to delabel them of the antibiotic allergy, we find that they are not allergic to the antibiotic.